Good evening to you all. I hope you are doing very well.
Good evening.
Yes,
Good
please.
evening.
Good evening, sir.
Good evening. Good evening. How are you?
We are fine.
Thank
We
God.
are fine.
Thank God.
Please, how are you too?
Oh, I'm doing very, very good. Very, very good. By God's grace.
We thank God.
Last week, what did we discuss? And we ended at what?
Alzheimer's disease.
Alzheimer's disease. So we finished with Alzheimer's, right? So that's good. Today we want to look at headaches. And if we finish, we look at another condition called epilepsy. If my voice is down, you tell me, okay? Yes. So you can hear me well. If you can't hear me well, tell me. So we wouldn't waste much time because we want to consider two conditions today, and that is headaches and epilepsy. So I want to take you through headache quickly and move on to epilepsy if time permits us. So headache. Everybody might have suffered from headache one way or the other. It's a very common symptom, and almost everybody has suffered one way or the other about headache. It's also known as cephalgia. And we talk about cephalgia or headache as pain arising from the upper part of the neck and the head. So any pain that is related to upper part of the neck and the head is described as headache. Scientific word called cephalgia. Cephalgia. If you talk about physical complaints, it's one of the most common physical complaints we normally talk about. If you look at the classifications of diseases, symptom doesn't have a class of diseases. It's just a symptom. So if you get malaria infection, you can have signs of headaches or symptoms of headache. If you suffer from any bacterial infection, you can have symptoms of headache. If you undergo a lot of stress, we will discuss today, and in response to the stress, you can experience signs and symptoms of headache. So headache doesn't have a specific class of disease. It's more of a symptom than a disease. Most of the times when you experience headache, it may indicate an organic disease or a disorder or a disease affecting the nerves. Either when we talk about organic disease, there is an existing pathological condition in the body. That is what can bring about headache. Could be a tumor, could be low blood flow, could be vascular disorders or disorders of the nerves. Could be a response to stress, so much stress and anxiety. Could come as a result of excessive vasodilation, and that is mostly marked by migraine. So migraine that is normally experienced as headache is due to excessive vasodilation of the blood vessels. Skeletal muscle tension, we call it tension headache. It also comes as a combination of factors. It could come as a result of so many factors. I can mention few. If my voice is low, you should tell me so that I adjust the microphone. How do we classify headaches? We divide headache into two major types. We have the primary headache and the secondary headaches. If we take the primary headaches, the most common ones include migraine, tension headache, and cluster headaches. Major classification, we have two major types: primary headache and secondary headaches. If we take primary headache, we are talking about migraine, tension headache, and cluster headaches. Migraine, tension headache, and cluster headaches, they come under primary headaches. If we want to talk about the International Headache Association or Society, there is a society internationally that looks at headaches. So we have International Headache Society classification of headaches. That society classifies headaches into 14 types. 14 types. Unlike the general classification or general types, where we have two major, primary and secondary, if we want to look at the international classification of headache, the society, we have 14 classifications. The first is the migraine. The second is the tension type headaches. And the third is the cluster headache and other trigeminal autonomic disorders. We also call it Caffardius. Then we have other primary headaches. We have headaches attributed to head and neck trauma. So you could have or you could sustain trauma to the neck and head, and that can lead to headaches. Headache attributed to cranial or cervical vascular disorders. So this is talking about the blood vessels, the caliber of the vessels that the blood runs through. Is it constricted or dilated? We have headache attributed to non-vascular intracranial disorder. This one, it doesn't have anything to do with blood vessels, but which is found within the cranium. So it's a cranial, intracranial disorders. Headache attributed to substance or withdrawal. It's withdrawal. So if you are using a specific substance and you want to withdraw from that substance, we call it withdrawal symptoms. And headache is one of the classical signs of withdrawal symptoms. We have headache attributed to infection, like malaria infection, bacterial infection, viral infection. Headache attributed to disorder of homeostasis. For example, homeostasis, we are talking about maintenance of internal body environment despite changes externally. So if the homeostasis mechanism is broken down, headache can occur. For example, one of the homeostasis mechanisms that control the body's physiological activities is the secretion of ADH, antidiuretic hormones, from the pituitary gland. In response to dehydration, the body homeostasis mechanism stimulates the pituitary gland through the hypothalamus, telling the pituitary gland to produce enough of ADH. So during dehydration, ADH is produced, and when ADH comes to the body, it tells the body not to produce so much urine because the body is having low fluid in circulation. So the presence of ADH closes the kidney tubules and retain fluids within the body to balance the dehydration and to restore fluid balance. That is the presence of ADH. In situations where the body senses that it has too much water in the blood volume, too much fluid, there is excessive fluid within the circulatory system, then the same body stimulates the pituitary gland through the hypothalamus and tell the hypothalamus to stimulate the pituitary gland to produce or to reduce the production of ADH. So it holds on to ADH, and ADH is not produced. In situations where we have deficiency in the blood of ADH, the kidneys become permeable to excessive diluted volumes of urine in an attempt to excrete excess fluids from the circulatory system. So you produce volumes of diluted urine in situations called diabetic insipidus. This is how the body homeostasis works. If in any case, if homeostasis is broken down, then in times of dehydration, you may not have the presence of ADH, and ADH may be still deficient. And when the body is dehydrated, you may still pass urine in the absence of ADH, and that one may cause excessive dehydration, which can stimulate headaches, brings about severe headaches when the homeostasis mechanism is disturbed. Headaches or facial pain attributed to disorder of cranium, the neck, and then the eyes, the ear, the nose, the sinuses, the teeth, the mouth, or other facial or cranial structures. These headaches affect the facial muscles, facial structures. You could see the person's eyes becoming too red, and the person complains of pain around the periorbital areas, the pain around the neck areas, around the ears. Headache attributed to psychiatric disorders, especially depression. If you suffer depression, you experience a lot of persistent headaches, normally frontal, and you have to be given to a psychiatrist for treatment, put you on amitriptyline, tryptizol, to control the headaches. So some psychiatric disorders can attribute or can contribute to headaches. Cranial neuralgias and central causes of facial pain. Cranial neuralgias. Then we have other classifications of headaches. So the International Society classifies headaches into 14 main types. If you look at primary headache, we are saying that it is one for which no organic cause can be identified. There is no pathological changes in the body. No organic cause can be identified. The types of headaches that comes under primary headache include, we mentioned as migraine, tension headache, and cluster headaches. Migraine, tension headaches, and cluster headaches. Migraine. Migraine is a complex of symptoms characterized by periodic and recurrent attacks of severe headache. So the word here should be taken care of. We have periodic and recurrent attacks. And the adjective here is severe headache. And the headache lasts from 4 to 72 hours, which means it comes within a day to 3 days. Persistent headaches. So that is migraine. It's a complex symptoms, normally periodic and recurrent. It keeps on happening, keeps on occurring. And when it occurs, it gives you very severe headache. And it could last from a day to 2 to 3 days. That is migraine. The cause of migraine has not been clearly demonstrated or understood by researchers. However, it is primarily a vascular disturbances. So it involves a disturbance of the blood vessels. And it occurs more commonly in women and has a very strong family relation. So the literature says that females complain migraine a lot more than their male counterparts. That is research. And it has a genetic tendencies to run in certain families. In certain families, as you hit a certain age, you start experiencing headache. So it has a strong genetic relations. There's one theory that says that migraine headache is caused by cerebral vasoconstriction followed by vasodilatation. So the blood vessels changes shape in terms of diameter. At a point, it experiences vasoconstriction. At a point, it experiences vasodilatation. When the blood vessels are subjected to vasoconstriction, vasodilatation, it leads to severe migraine. That is what the theory is saying. How does the vasoconstriction occur? The vasoconstriction comes as a result of a response that has been triggered by the trigeminal nerve. So the trigeminal nerve is the cranial nerve 5. As you stimulate the cranial nerve 5, the trigeminal nerve, the blood vessels undergo vasoconstriction. So the trigeminal nerves, when stimulated, leads to the release of a substance called substance P. And substance P is responsible for transmitting pain. They are pain transmitters. So once you stimulate the trigeminal nerve, which is the cranial nerve 5, there is the release of substance P, which helps to transmit pain. And once the pain is transmitted, it goes into the blood vessels. And in the blood vessel, there's the release of amines, such as serotonin, norepinephrine, and epinephrine. These causes vasoconstriction. So the release of substance P after triggering the cranial nerve 5 and the trigeminal nerve, you release a substance called substance P to help transmit the pain that comes as headache or migraine. After which, there's also the release of certain stimulants called amines. And these amines are serotonin, epinephrine, and norepinephrine. They all help to sustain vasoconstriction because they are sympathetic hormones. They are sympathomimetics. And once you stimulate the sympathetic hormones to flow, you get the vasoconstriction. So migraine can be triggered by menstrual cycles. There are some women, as they approach ovulation, they experience severe headaches because the hormones are at their peak. You have the estrogen and progesterone rising to their peak, getting to ovulation time. Others, when the hormones start withdrawing, the estrogen and progesterone start going down. Then at the lowest point, when they are about to get their flow, they also experience headaches. So women tend to experience headache along the menstrual cycle. Some see bright light. When you see bright light, some experience headache. It stimulates the nerve to start experiencing headaches and migraine. Some through stress response, and some to depression. Others, sleep deprivation. She has contracted the night duty, so she has never slept so long in the night. So you deprive yourself of sleep, and your brain, you lose concentration. You have so much activity on the brain. So we have sleep deprivation. If you don't sleep, you have severe headaches. Once you sleep, the headaches disappear because you recover. Fatigue. You get too fatigued without rest. It can induce headaches. Overuse of certain medications. You get addicted to it and you can't come out. Also, certain food containing tyramine, monosodium glutamate, so certain food, we talk about tyramine, monosodium glutamate, nitrates. Certain food contain nitrates. And the nitrates stimulate the endothelium of the blood vessels to produce vasodilatation. So anytime you take food containing nitrates, it helps to dilate the blood vessels. It releases a substance called nitric oxide. Nitric oxide helps to dilate the blood vessels to improve circulation. So food containing nitrates will stimulate the production of nitric oxide and therefore production of vasodilatation, which can cause migraine. Certain milk product, when you take, can cause this migraine. Those that are triggered by food also include aged cheese that has been aged, many processed foods, the use of oral contraceptives, and this may be associated with increased frequency and severity of attacks in some women. So certain type of people, they abuse the contraceptives, especially the oral ones. That person every day is emergency. So personal 2 emergency, personal 2 emergency. Don't know what you are taking inside the body. 2 tablets of personal 2, as if you are taking a whole month of secure or other progesterone-only contraceptives, a whole month. So it's highly concentrated and packed. It is only used as an emergency resort, but for you, every day is emergency for you. It can stimulate a lot of migraine and can increase the frequency and severity of the migraine because of hormonal imbalance. The typical time of onset is at puberty. Mostly the adolescents experience it around puberty. And the incidence is 18% in women and 6% in men. So the men do have lower risk here. lower risk. The commonly used descriptors of migraine when patients come to the hospital and they are describing the migraine, the kinds of words they use is throbbing, boring, vice-like, pounding. Doctor, meeting the bomb say, keep pounding. As if we are pounding fufu. And the migraine pain is usually on one side of the head. If it's on the right temporal, it's on the right temporal. It's on the left temporal, it's on the left temporal. It's at the occipital, it's at the occipital. If at the frontal, it's at the frontal. Only on one side. During the periods of migraine, patients do not, or clients do not like noise and light. When they are exposed to noise and light, they tend to worsen the headache. And therefore, they go and seek dark, quiet environment because they are running away from the stimulants. The light may stimulate them, the noise may stimulate the trigeminal nerve and the release of these AMIs. So during period of attacks, clients go and seek a refuge in quiet, dark environment. Areas afraid of light, so there's no light, no noise, quiet place. There are two major types of migraine. We are saying that the major type of headache, we have two. We have primary headache, we have secondary headache. If you take the primary headache, we have three sub-classifications under the primary headache. We have the migraine, we have the tension headache, and we have the cluster headache. If you take the migraine, we have two subtypes of migraine. We have migraine with aura and migraine without aura. The aura is the warning sign. You take the warning sign. So we have the migraine that comes with a warning sign, which means you experience certain signs or certain symptoms that tells you that migraine is about to occur. Migraine is very imminent. Then you also experience another type of headache which does not give you the aura. So there's no warning sign. And that one is dangerous. So that is the two main types of headache, migraine. Migraine with aura and those without aura. Now we have four main phases that you go through during experience or those who experience migraine. You go through four main phases. The first phase is prodromal phase. From the prodromal phase, you come to the aura phase. From the aura phase, you go to the headache phase and the resolution phase. So four phases experienced by migraine clients. Prodromal phase, aura phase, headache phase proper, and the resolution phase. What happens during the prodromal phase of migraine? This prodromal phase is experienced by 60% of patients, 60%, with symptoms that occur hours to days before migraine headache occurs. So you may experience the prodrome within some few days, hours to days, some 3, 4, 5 days. Then the migraine will set in. So those signs that you experience, the symptoms, include depression. You can have depression. Some days after the depression, you experience severe migraine. Irritability. become very irritable, very agitated. You can experience these are the prodrome phase. Feeling cold. You crave for food, food craving. So some people, they become anorexic, changes in activity level, some increase urination, some have diarrhea, others have constipation. Some patients may have the same symptoms here in each of the migraine attacks. You go through the same symptom, then it tells you that some few days to come, you have severe migraine. That is the prodrome. The aura phase is the warning phase. And this occurs in a minority of patients who experience migraines. Very, very minority, the warning sign. The aura phase occurs in a minority of patients who experience it. The aura list usually lasts less than an hour and may provide enough time for the patient to take the prescribed medication to avert an attack. So the aura phase may come around 40 minutes to the attack, may come around 30 minutes to the attack. So the individual senses the danger that a migraine is imminent, will go and take his anti-migraine medication. Then it will stop the migraine from occurring. So the aura phase is an alert phase. It draws your attention that migraine is about to occur. So take your medications. So the person rushes to take his or her medication and it will avert the attack of this headache or migraine. The period is characterized by focal neurologic symptoms, visual disturbances, light flashes, and bright spots. They are most common and may be hemorrhagic. So hemorrhagic, you see things half-half. So you see things half-half. Other symptoms that may follow include numbness, tingling of the lips, face, or hands, mild confusion, light weakness of an extremity, drowsiness, and dizziness. Jemima Augustina Dufour. Jemima, mute your microphone. So that is the aura. It gives you a warning. And those warning, when you see them, sometimes bright spot flashes of light, like epileptic sign. You rush and then you go and take your medication to stop it from occurring. That is the meaning, aura. Then the actual headache phase. The actual headache phase there's vasodilatation and a decline in serotonin levels occurs. So we said that initially that migraine can occur when there is vascular disturbance. So at a point you have vasoconstriction, at a point you have vasodilatation. So here, when migraine occurs with vasodilatation, it means that those amines that cause vasoconstriction, their levels should be low so that the blood vessels can dilate. In the presence of the constrictors, the epinephrine, the norepinephrine, the serotonins, those, when they are present, there will be vasoconstriction. So if migraine should occur with vasodilatation, then it means that the constrictors should be low. So you have low levels of serotonin levels, low levels of epinephrine, low levels of norepinephrine, and all the sympathetic hormones, they are all low. So definitely, if there is migraine with vasodilatation, that is migraine related or vasodilatation that brings about migraine, and the blood vessels may be excessively dilated, and you should have all the sympathetic hormones very, very low. So they have a throbbing headache, normally unilateral in about 60% of patients. And this normally intensifies over several hours. It is too intense. And the descriptions are a severe and incapacitating headache. And it goes along with photophobia. So you run to the dark, nausea, and sometimes vomiting. The duration varies and ranges from 4 hours to 72 hours. That's a day to 3 days. So imagine going through so much pain, very severe and incapacitating pain within 3 days. It's not easy. So they suffer a lot. After this period of headache phase, you go into a period of resolution phase. Resolution phase. So the resolution phase, that is the termination and post-drop. So the signs that were experienced, all of them are coming to a very low levels. They are coming down. The pain gradually subsides. And when it subsides, you see muscle contractions in the neck and the scalp. Very, very common. So the scalp muscle, the neck muscle, all set into contractions. And sometimes you feel muscle aches and localized tenderness. You feel so much exhausted, and your mood may change out of the exhaustion. You have mood changes. Any physical exertion will worsen the headache pain. So here, you don't want to exert anymore because you have suffered for the past 3 days. So as resolution occurs, you don't need to exert again. If you exert yourself again, the pain recurs and it will get worse. So during this post-headache phase, patients may sleep for extended hours because they are tired, they are exhausted. The body needs to heal the inflammations. And the body heals inflammations by putting the body to sleep. As you sleep deeply and in extended hours, you recover all the inflammations. Now you get better. We move from migraine headache to tension or muscle contraction headaches. tension or muscle contraction headaches. They tend to be chronic and less severe, and are probably the most common type of headaches. Tension or muscle contraction headache is the most common type. If you take the three of the primary headache, the tension one is the most common. There's persistent contractions of the scalp and the facial muscles, cervical, and the upper thoracic muscles. And this can cause tension headaches. So when there is contraction of the scalp, facial, cervical, and upper thoracic muscles, this occurs. A cycle of muscle tension, muscle tenderness, and further muscle tension is established. So like that, it goes in a cycle. This cycle may or may not be associated with vasodilation or cerebral arteries. So this type of tension headache has nothing to do with the caliber of the blood vessels. It is marked by contractions of the muscles, normally around the upper thoracic, the neck, the facial muscle, the scalp muscle, but has nothing to do with the caliber of the blood vessels. Headache of this type can be associated with premenstrual symptoms. So the premenstrual symptoms or psychosocial stresses, such as anxiety, emotional distress, or depression. As women go through premenopausal symptoms and menopausal symptoms, most of them are subjected to muscle contraction headaches or tension headaches.
Nipona. No, that one, no, the one about
Francis Etruba White. Etruba White, your voice is everywhere. Everybody is listening to your conversation. Why? We ask you to mute as you connect. You connect late and you unmute your microphone and you disturb the class. Why? So here, there is vasodilatation of cerebral arteries. Headaches of this type can be associated with premenstrual syndrome or psychosocial stresses such as anxiety, emotional distress or disturbances, and depression. Symptoms of this tension headache typically develop gradually and radiate, mind you, they radiate. The migraine headache doesn't radiate, it's unilateral. But this radiates. So the radiation of pain to the crown of the head and base of the scalp. So from the crown to the base. But migraine headache is unilateral. It's always restricted to one part of the head. With variations in location and intensity, very, very common. The adjectives they use to describe is pressure, there's aching, and there's steady and tight. So the headache, in terms of intensity, the migraine headache is more intense. The adjectives in migraine headache was incapacitating severe headache. By this time around, there's heavy headache. Steady. It's not that serious. Tight, aching, pressure. These are some adjectives they describe the pain of tension headaches. Then we move to the last classification of primary headache, which is the cluster headaches. Cluster headaches. The cluster headaches are a severe form of vascular headaches, which behaves like the migraine headache. The migraine headache is a vascular disturbance as well as the cluster headaches. However, the tension muscle or muscle contraction headache is contractions of muscle. It has nothing to do with bulk of the blood vessels. They are seen 5 times more frequently in men than in women. Mind you, the migraine headache was more of women than men. More of women than men. But the cluster headache prefers more men than women. More than 5 times in men than in women. The pathophysiology of cluster headache is not fully understood theoretically. We don't really know exactly what brings about this. There's a theory that is caused by dilatation of the orbital and nearby extracranial arteries. So here, the arteries around the orbital and then the periorbital and the cranial extracranial arteries dilate excessively. And this causes the cluster headaches. The patient experiences attacks of severe or very severe, just like the migraine. Strictly unilateral, just like the migraine. And mostly it occurs around the orbital, supraorbital, and the temporal pain. It lasts about 15 to 180 minutes, whereas the migraine headache lasts about 4 to 72 hours. At this time around, cluster lasts up to 15 to 180 minutes. And occurs once every day. So every day you may experience this type of cluster headache. And if it occurs within a day, it can occur as frequent as 8 times in a day, at least for 8 days. So within 15 to 180 minutes, it lasts. But 8 times a day. 8 times a day. So much. The descriptors, the thrombin, excruciating, are often the adjectives used by the patient. So this is also very severe, just like the migraine pain. The one that is less severe and steady is the muscle contraction headache. But the cluster headache is just like the migraine. Say excruciating pain, throbbing pain, they are severe pains. Then we come to secondary headache. Here we have an organic cause, underlying pathology, such as brain tumor or an aneurysm. Aneurysm is a dilatation or pouch-like dilatation, protruding of a wall of an artery. Pouch-like dilatation of an artery. When artery wall becomes weak and pressure builds within them, it protrudes and forms something like a bulge. That is called aneurysm. It can rupture and leads to ruptured aneurysm. It could occur within the central, or others can occur peripherally. And brain tumor, when it presses on a nearby nerve, cranial nerve, gives you the constant headaches. We also have cranial arthritis. And this cause of headache in the older population, from 60, 65, 70, 75 and above. They normally experience a type of headache called cranial arthritis headache. That's an inflammation of the vessels. And it happens around those in 60, 70 years of age, 70 years. Cranial arthritis, the kind of headache. The inflammation of the cranial arteries is characterized by severe headache, localized in the region of the temporal artery. So the pain is limited around the temporal area. Temporal area. The cranial arthritis often begins with general manifestations such as fatigue, malaise, weight loss, and fever. Signs of inflammation set in here. Clinical manifestations associated with inflammations. So we have So if the blood vessel that supply blood to the orbital arteries, sometimes there could be ischemia, and that may cause visual problems. A detailed history which focuses on assessing the headache itself, with emphasis on the factors that precipitate or provoke it. The patient is asked to describe the headache in his or her own words. So the patient may tell you that anytime I eat certain food, I start experiencing this headache. Anytime I go into serious anxiety, I experience this headache. Anytime I'm depressed, I experience this particular headache. Anytime I'm about to ovulate, I experience this severe headache. So based upon what the patient tells you, you gather your information. You can arrive at certain diagnosis and confirm it with these radiological investigations like CT scans, cerebral angiography, cranial nerve testing. So you are testing whether the cranial trigeminal nerve is stimulated to release substance P, which is a pain transmitter, and the release of the amines. Cranial nerve testing. X-rays, MRI to detect whether there's any sort of secondary type of headache, tumor of the brains, aneurysm of the central arteries. You want to detect any underlying cause, such as tumor aneurysm. Electromyography, an instrument used to measure the waves and that is felt pressure around the muscles. And this helps to diagnose muscle contraction headaches or tension headaches. Reveals sustained contractions of the neck, scalp, or facial muscle. The therapy for migraine therapy is divided into abortive, symptomatic, and preventive approaches. So when you talk about the symptomatic one, we call it abortive one, and then preventive approach. The abortive approach best used in those patients who have less frequent attacks. And this is aimed at relieving or limiting headaches at one set or while it is in progress. So once the headache sets in, you limit the intensity and the frequency of the headache. When you want to use the abortive approach, here the pain has set in and you are controlling the pain so it doesn't progress. Control the pain. Abortive approach, symptomatic approach. The preventive approach is used in patients who experience more frequent attacks, whereas the abortive one, the attack is less frequent. But for the preventive, the attack is very, very frequent and at regular or predictable intervals. So you can predict when the attack will occur, and therefore you take your medication to avert the occurrence. Some of the patients may have a medical condition that prevents them from using the abortive therapy, and therefore they go for the preventive therapy. So those patients who may be contraindicated because of a medical condition underlying, we use the preventive approach for them. If the abortive therapy may be contraindicated, we push them to use the preventive approach. The triptans are used to control severe migraine. The triptans, they are called the serotonin receptor antagonist. So if it is caused by vasoconstriction, then we have a medication that antagonizes the receptors to these amines, so they don't undergo vasoconstriction. So we have the triptans. And the most specific anti-migraine agents available here They cause, if it is vasodilatation, they cause vasoconstriction, they reduce inflammation, and they may reduce persistent transmission that by blocking the release of substance P. The 5 triptans in routine clinical use include somatriptan or somatriptan, naratriptan, rizatriptan, zometriptan, and amitriptan. They are the triptans. Then, if it is cranial arthritis, the inflammation, we use the NSAIDs, non-steroidal anti-inflammatory drugs, such as naproxen EC, may be first tried. So we try first on naproxen EC. If it doesn't resolve, then we move on to Pafigot, known as the ergot. It's one of the strong anti-migraine medications, Pafigot. A vasoconstrictor. So we use it for vasodilatation migraines because it's a vasoconstrictor. It rather will cause the blood vessels to go into vasoconstriction if it is vasodilations. It's effective only if taken before the vessels walls become edematous and dilate, usually within 30 to 60 minutes of headache onset. At worst, we can administer upwards, and these ones are habit forming, so we are less careful. We are more careful, sorry, and we use them less. We don't want to form habits among these drugs, like tramadol, morphine, petidine, and the rest. We don't normally administer them because it can be habitual, can form addictions. The medical management of an acute attack of cluster headaches may include 100% oxygen by face mask for 15 minutes. So they give you 100% of oxygen when it is cluster headaches. We give corticosteroids, and these are anti-inflammatory ones, or percutaneous spinopalatine ganglion blocks. The anesthetics can easily block this particular nerve and relieve you of the pain. The medical management of cranial arthritis consists of clearly administration of corticosteroids. Because it is inflammation, the steroids will reduce the inflammation, prevent the possibility of loss of vision because of attack of inflammation on the periorbital arteries, the orbital arteries, and extracranial arteries. These arteries are inflamed, and therefore, the systemic corticosteroids will cause resolution of these inflammations. So, loss of vision due to vascular occlusion or rupture of the involved artery could be prevented. The administration of the steroids. The patient is instructed not to stop the medication abruptly because this can lead to relapse. Any time you are using steroid medication, don't stop it abruptly. It can lead to relapse. You reduce it gradually. So you reduce it. If it is 50 milligrams BD, you come to 10 milligrams BD, you come to 5 milligrams BD, then 2 milligrams BD, like that. How do we manage them? The goal of the management is to treat the acute events of the headache and to prevent recurrent episodes. We want to reduce the number of times you experience this headache because it's so uncomfortable. Then the patient is assisted to be able to identify the trigger factors. Those things that she does that brings about this headache. Then we advise her to move away from those ones. So identify and reduce aggravating factors. And this can be accomplished by keeping a headache diary for a time. So you have a headache diary, and anytime you open the diary, you record the number of times the headache occurs, how intense it was, the food that you took that brought about the headache, So all these, recording the time of day the headache occurs, the food eating, any aggravating factors. Description of the pain, is it unilateral or bilateral? Is it radiating? Identification of associated symptoms such as nausea or visual disturbances. Other factors related to headache symptoms, identification of triggers can help the patient lessen the frequency and intensity of attacks. That is why we give the headache diary. We keep it to identify the trigger factors. We encourage the patient to use alleviating techniques such as biofeedback, stress reduction techniques, meditation techniques, and exercise programs. You go for jogging and you forget about everything. If it is stress, you listen to your music, cool music, in a very quiet, dark room. This helps the patient participate in the treatment of the headache and provide a sense of control over his or her own illness. Teach the patient to use relaxation exercises and warm or cool moist compresses or applications. So if there is vasoconstriction related headache, you apply the warm compress to cause dilatation. If there's vasodilatation and migraine, then you apply cold compress to cause vasoconstriction. So depending upon the type of headache, you apply either cold compress or hot compresses. So give a dark room and rest to reduce stimulation during migraine headaches. Teach the patient about medications, appropriate dosage, expected action, side effects. That is, so you take the patient through pharmacodynamics and pharmacokinetics and the consequence of misuse. So the patient also needs to be taught about pharmacokinetics and pharmacodynamics at home, so he can follow the regimen. Any questions so far from the headaches? Any question so far? Yes, it's true. Some people get headache when they are hungry. That is true. You know, the brain depends upon 95% of total body glucose. Anytime you are hungry, definitely you experience headache. Yes. Yes. That is true. That is true. That is Priscilla. Yes, you get hungry and you get headache. That is true. Okay. Gladys' hand is up. Gladys, let's hear you, Gladys.
Okay, sir, good evening.
Good evening.
Sir, please, with the management of the cluster headache, you made mention of patient to be administered to be given oxygen at 100%. So I want to know if the patient is not desaturating. A person saturation level is around 100%. Are you still going to give that oxygen?
So by 100%, the symptoms will be over. You know, anytime we tend to administer oxygen, we are sure the saturation level is low. That is why the patient experiences these signs and symptoms. So we try to saturate the patient at a level we see that the signs and symptoms are over, then we can stop it. So saturation levels will definitely affect or relate to whether the symptoms are over or not.
Oh, okay.
So, yes. So anytime, because the patient will not be just straight away going to be given oxygen administration without checking the saturation levels and knowing the reason why they are giving the saturation at that particular time and the levels. So once the saturation levels falls, it will come along with the pain or specific symptoms. And therefore, that will require that they give the patient specific amount of oxygen to reduce the pain.
Okay. Thank you.
All right. Okay, so from Cosmos, no, Jamfi, Cosmos. So Jamfi says, write your question down as you, also, yes. Jamfi was trying to help me. Once you write your questions down, I will look through. Yes, I've answered that. Hunger can lead to, I've answered that. Hunger can lead to headaches. Yes, hunger. Yes, thinking, overthinking. Yes, stress. Once you think and you think, you release the stress hormones, the amines, the serotonin, the adrenaline, noradrenaline, and they cause vasoconstriction. Definitely, you can. Yes, Ali, let me hear you, Ali.
Thank you. So the migraine headache that you talk about, is it something that can be treated completely with medication? Because I know somebody that has been coming with it. Then you give medication, the person go. The next time the person comes again. Thank you.
Ali, if you could remember what I said, the best management of migraine headache is to identify the trigger factors and move away from the trigger factors. And that gives about 90% management. The person should take a diary, migraine diary, headache diary, and record in the diary the previous activities he did that led to the next day having the migraine, including the food she took, the kind of activities she went through, and before she experienced this particular headache or migraine. So keep into all the diary, write them inside. By this, we'll be able to identify that ABC may be the trigger factors for your migraine. So move away from that. That is the best management so far. That is the best management. But we don't have a particular, all the medications there are to manage you, to reduce the symptoms, reduce the frequency of attacks, and to limit the intensity, but not to cure. Not to cure. So we manage.
Thank you, sir.
All right. Any questions so far? From Owusua Mavis. Mavis is asking, so please, can migraine be a cause of hemorrhagic stroke? So during cranial arthritis, some of the arteries may be inflamed. And once there's slight increase in pressure, the pressure can cause dilatation of a weakened wall, and that can definitely rupture. And it can cause hemorrhagic stroke. Even the aneurysm, when it ruptures, can lead to hemorrhagic stroke. So definitely, some of these can end up in hemorrhagic stroke as the vessel wall can rupture. So from Rebecca says that Alote said, please, does it mean the Posino 2 can protect one from getting pregnant for a month? Oh, Posino 2 is an emergency contraceptive. And once you take within 72 hours and you take the Posino 2 after sexual intercourse, it's known that you can avert or stop or prevent pregnancy. That is it. But it is meant for occasional use, not for frequent use. No, we don't use it like that because of the side effect and how it may affect your hormonal balance. So from Clinton upon says that when you read the leaflets inside, the maximum is 72 hours, yes. Meaning if you take, okay, he was responding to that, okay. Yes, Abu says when they will hear bedroom sound, I wonder which bedroom sound he's talking about anyway. Abigail is saying that. Abigail Mensa, please off your video. All right. So from Ruben says, sir, please, is double vision a sign of headache? You cannot say double vision is a sign of headache, but double vision may affect the cranial or the orbital arteries and the orbital nerves. So when the orbital arteries are affected, it can lead to cranial double vision, but might not affect or maybe brings about headaches or migraine. Could be as a result of hypertension. And remember, hypertension can also affect the orbital arteries, and that can cause double vision. Most of the visual disturbances is due to hypertension. And you know, once there's increase in the systemic blood pressure, it can affect the pressure within the eye, and that is the intraocular pressure can also increase. And once there's increase in intraocular pressure, definitely it will affect your vision. So in response to your question, definitely. Mary, your hand is up.
Thank you, sir. Please, I have my sister I don't know whether it is migraine or tension headache, but immediately she smells a very strong fragrance, the head aches like description to migraine, and then she would have nausea and then the vision that you're talking about, but it doesn't last for the whole day though. So I don't know whether I can classify that one under tension headache or migraine. Please help.
Okay, so whenever the person comes close to the fragrance,
strong fragrance,
yes, strong fragrance, it stimulates. So there's that stimulation. So it causes the vasoconstriction related migraine, and that is under migraine.
Okay.
So vasoconstriction related migraine. Okay.
Okay.
Yes.
Thank you.
Okay. So from Elam says, sir, please, does migraine cause vomiting and blurry vision sometimes? Because I have that once the orbital arteries are affected, definitely there will be blurring of vision. Definitely there will be blurring of vision. Okay. So we will, please, do we have some more questions? Okay, thank you. We will not stress so much. Would like to leave you, and once we don't have so much questions, we will end here. We will continue from epilepsy and multiple sclerosis next week when we meet. Multiple sclerosis and epilepsy. Thank you very much. I love you all. As some people, thank you so much. We'll meet again.
Please, there's
Bye-bye.
pineapple.
You see?